It's summertime, it's hot, it's baseball season, and in this episode, we're going to talk inside baseball about healthcare legislation and other initiatives as well. Welcome to the HealthLinks podcast, presented by the HealthLinks family of services. I'm your host, DJ Thatcher. Our mission here is to engage in conversations about the medical landscape of South Carolina so we're all better informed. So in this episode, we're at the headquarters of the South Carolina Medical Association in Columbia, joined by two of their leaders, Holly Pisarik, who is their Senior Vice President of Advocacy and Policy Counsel, and also Dr. Fritz Butehorn, who is the new President of the South Carolina Medical Association. Holly, Dr. Butehorn, welcome to the HealthLinks podcast.
Thank you. Thank you for having us.
Our listening audience is made up of both medical people and the lay public. So the medical people know what the South Carolina Medical Association is about, but the lay public probably does not. So, Holly, why don't we go to you first? Why don't you tell us, what does the South Carolina Medical Association do for patients and the public? Then we'll go to you, Dr. Butehorn. What are you doing for physicians? So, Holly, go ahead.
Sure. So as the South Carolina Medical Association, we represent thousands of physicians. Our mission is twofold. We represent the voice of physicians, but we also represent South Carolina patients. And we do that in a myriad of ways. We do it one through advocacy. So that's primarily my job. I'm involved with legislative advocacy. We also represent the voice of the patient. And we are involved in continuing medical education. And then we're just really involved in all healthcare conversations in South Carolina.
Okay. And from a doctor's standpoint, what does the South Carolina Medical Association provide for physicians?
South Carolina Medical Association is basically a support structure for all physicians, no matter their specialty in South Carolina. So our goal is to make sure physicians are up to date on all the changes in healthcare in South Carolina, no matter their status, employer, et cetera. We also want to make sure that physicians are available for patients in every aspect of healthcare in every location in South Carolina.
Good. Yeah, we'll talk more about that in a moment. So we got the South Carolina Medical Association, which maybe a lot of people have never heard of. We've got the AMA, the American Medical Association, which most people do. Then there's also county medical societies or associations. So what's the relationship among the three of those?
Traditionally, they were very tightly woven together, where you had to be a member of your county, you had to be a member of your state, and you had to be a member of the AMA to be a physician.
Okay.
That has broken down over time. So many physicians choose not to be part of the AMA, but many do. South Carolina Medical Association represents South Carolina at the AMA, and then counties also provide a structure for physicians in their local area to participate in the South Carolina Medical Association, and then therefore further up to the AMA.
I see.
And from an advocacy perspective, the AMA generally works on federal lobbying issues. We work on state level lobbying issues. Although we work some in conjunction with the AMA on federal issues, we primarily focus on state level advocacy issues.
You spend a lot of time with the state capitol, I bet, and all those people in your role.
All of our
you can tell us
representatives, the governor, yeah.
more about that. One of the successes that you helped to initiate was going back to 2023 with the repeal of the Certificate of Need legislation. And it was a big success. The lay public probably doesn't even know what that means. So if you could, tell us, what was that Certificate of Need all about? And why was its repeal so important?
Sure. So Certificate of Need was a program that was implemented back in the 80s. It was a federal initiative that then trickled down to the states. And when it was implemented, it was under an old payment model. And as the payment models evolved, it just didn't make sense anymore. It didn't make sense for hospitals or physicians to have to go to the government to ask permission to build a new facility, to buy a new piece of diagnostic equipment. Again, we represent the voice of South Carolina physicians, so access to care is important to us. Access to low cost, high quality care is important to us. So we saw Certificate of Need as an impediment to that. And so we successfully advocated for the repeal of Certificate of Need. And now hospitals, if there is a need for more beds in a community, they can just add beds without having to ask the government. If a physician has a need for a piece of diagnostic equipment, there's a need in the community, there's not enough, there's too long a wait times for an MRI or a CT scan, they can purchase that piece of equipment to fill the need in the community without having to go to the government and allow your competitors to litigate against you because they don't want the competition.
Okay. I know that when that was proposed, the argument was it's going to increase access to healthcare. It's going to reduce costs and really provide better treatment for patients. That's only been, a year and a half, but have you seen any of that come to fruition, or that's in the process?
Go ahead.
We do see it starting to have some ramifications. Okay. So as Holly was mentioning, the full repeal starts next year, but already we're seeing more healthcare facilities opening or being scheduled to open, especially in rural areas and underserved areas. We feel like it's going to be an excellent impetus for advancing healthcare opportunities for physicians in multiple areas throughout the state, and I'm already seeing that.
I could give you one specific example.
Sure.
So Fort Mill, the hospital being built in Fort Mill, was kind of the poster child of the need for repeal of certificate of need. It took about 15 years for that case to be litigated. So a need was identified for a hospital in that area. It took about 15 years to litigate it before they finally broke ground. By the time they broke ground, the hospital is probably too small to meet the community's needs. But we've already seen they broke ground a couple of months ago on a new ambulatory surgery center, which would have not been possible with certificate of need in place, because that again would have been very protracted litigation. So now Fort Mill residents will have another option for a site to get surgery.
As you drive around the state, you see this explosive growth of healthcare systems, hospitals, clinics in most of the major areas, for sure. So
we're excited about that as the SCMA. I've spoken with many hospital administrators, for example. I'm from Spartanburg, and our local hospital administrator said he's looking to hire 200 more physicians in the coming several years.
Wow.
Milk University, South Carolina, looking to grow by 10% in the coming year or two. So we're really seeing explosive growth in physicians. And part of our job at the SCMA is try to help attract physicians to the state and help keep them here.
Yeah. It's a big initiative, for sure.
Yes.
Well, congratulations on being elected president. I know as the president-elect, you were key with working with the legislature and so forth. You were just elected, in April at the annual conference of the SCMA. So as the incoming president, I know one of your big initiatives is to help promote physician-directed health care. Tell us a bit about that and some of the other initiatives that are on the horizon.
Well, in South Carolina, as in many states, there's a lot of concern about access to healthcare. As we mentioned before, we're a fast-growing state, and that requires physicians to help take care of patients. Unfortunately, many in our legislature believe that access to healthcare means access to anyone, which could be a nurse practitioner or a PA or other healthcare providers that aren't physicians. We know that physicians provide the best care. That's borne out by research. In our membership, we like to support our members through advocating for our profession at the State House.
Okay.
As a matter of fact, we had a senator recently talk on the state floor about healthcare and the lack of healthcare, and bemoaning the fact that there weren't healthcare providers in rural areas. And he spoke about how that's the reason they needed to let nurse practitioners or PAs see patients without physician insight. However, shortly before that, he mentioned that the best healthcare he ever got was from his family physician in his small town. And our argument is that that still is the best healthcare, and there's no reason why you can't have a physician manage your healthcare, no matter what location you are in South Carolina. Sure. So that is our primary reason to be advocating for physician-led healthcare in South Carolina. We think it's important for our patients.
Good. Well, we highlighted the success of the repeal of the certificate of need. One of the other hot buttons right now is the whole idea of non-compete agreements and so forth. And in fact, a shameless plug here. So we do have the SCMA magazine that's new this year, published in conjunction with HealthLinks. And in one issue here, a whole article about the conundrum of non-competes. So what is that all about? How would these non-compete agreements affect patients and then also doctors?
Sure.
Where do we go from there?
So I'll speak from the patient perspective.
Sure.
So we think the repeal of non-compete, or the prohibition of non-compete agreements in physician contracting, really is solely about the patient.
Sure. And by the way, what is a non-compete agreement anyhow? Sure. We should probably start with that.
So basics. It is a clause in an employment contract that prevents a physician, if they leave the healthcare facility or healthcare setting that they're currently practicing in, it prohibits them from practicing in a certain geographic area in a certain specialty for a certain amount of time. And there are many states that prohibit that practice. And the reason that they prohibit that practice is because when a physician signs that contract, what they're doing is contracting away their patient's right to choose their physician. So I'm a lawyer. As a lawyer in South Carolina, I'm ethically prohibited from signing a non-compete agreement because I cannot contract away my client's right to choose me. Dr. Butehorn, his patients probably love him. He's an amazing guy. He's an amazing doctor. If he were to choose to leave his healthcare setting, it's not fair for his patients who may have seen him for years to be prevented from seeing him simply because he's no longer happy in the employment setting he's in. So we think that for the same rationale for lawyers equally applies to physicians, if not more, because being a patient is sometimes more sensitive than even being a client of a lawyer. So that's the right we're trying to protect.
I got you. What's the status right now of the
there's a Senate bill, Senate Bill 46. It's sponsored by Senator Tom Davis. It was introduced. It's had its first subcommittee hearing. As you know, we're in the first year of a 2-year legislative session. Right. So it didn't move out of subcommittee this past session, but it will still be alive and well on the calendar when they reconvene in January.
You kind of camp out there, I bet, during the sessions, huh?
I do. Yes.
Gotcha. So, Dr. Butehorn, from a doctor standpoint, how does this affect doctors and non-compete agreements?
Well, as Holly said, it's all about the patient-physician relationship. So when you establish that relationship, it's a bond, a trust thing. And once that's violated, the patients feel very isolated. And right now, the way it works is if you choose to leave your position, the employer can prohibit you from contacting the patient even to let them know that you've gone. And many times you show up at your doctor's office and you end up getting assigned to another physician. We don't really think that's appropriate. We think it will, by removing this clause, will allow physicians to continue their relationships with their patients, which is the right thing to do for patients, also the right thing to do for physicians. I know many physicians who have, for whatever reason, chosen that their current status was not what they wanted to do, and they have to leave the state, for example, which is not a good thing, leave the area, and their patients are left in limbo for periods of sometimes 1 year, 6 months, 2 years until they can come back to the area. We don't think that's appropriate.
Sounds, it sounds like a great initiative. So, all right. Well, you mentioned earlier, we have some challenges here in South Carolina from healthcare. Depending on who you reference, we're toward the bottom in healthcare. I mean, I think we're ranked like number 37 out of the 50 states in the healthcare outcomes. We're a leader in heart disease and diabetes and chronic kidney disease and so forth. So we obviously have issues. Saw an article, Newsweek Online, just a couple of weeks ago, that ranks South Carolina only number 2 behind New York in being the worst for access to care of patients. And I'm curious, number one, what that really means when you say access to care. Because no matter who I am, I can call 911 or go to an emergency department and be treated, so I can access healthcare. But what does that really mean?
It would be interesting to see what that data was. We do not deny that there's healthcare access issues, and that's throughout the country, throughout the world, actually. We believe that physicians are the answer to that healthcare access issue. And as South Carolina is a rapidly growing state, I would not be surprised that the healthcare access is becoming worse. That is absolutely why we feel like there needs to be more physicians. And physicians see more patients than other providers. So therefore, one of the solutions is often offered is to just open up and let other types of providers see patients. That may be temporarily useful, but if you see, for example, a family medicine physician can see about 30 patients approximately in a day, whereas another provider may be able to see 10. So you're going to have 3 providers that see 10 each, or 1 family medicine physician that sees 30. So we feel like the right answer for patient access is more physicians. And our goal is to help train more physicians in our state. We're trying to expand not only medical school slots, but residency slots. So that is where if a physician is educated in a state, they're more likely to stay in that state. However, if they also do their residency program, they're much more likely to stay in the state. So you mentioned we are a potentially low access area. A solution to that is educating more physicians in our state, having them stay in our state.
Okay. So there are 4 medical schools in the state, if I'm correct. How many physicians do they graduate every year? Do you know offhand?
So I don't know the exact
I'm not
number.
sure.
What I do know is in 2005, the Council on Graduate Medical Education identified this shortage that was coming.
Sure.
And so South Carolina has done a tremendous job since 2005 to try to ramp up the supply. So since 2005, we've opened 2 new additional medical schools. We are pumping out 150% more medical students than we did in 2005.
Okay.
We've got 118% more residency slots
Oh, good.
in South Carolina than we had since 2005. What we need to work on now is retaining those medical students and those residents, because as Dr. Butehorn said, if you go to medical school in South Carolina, 45% of South Carolina medical students ultimately practice in South Carolina.
So less than half.
45% of people who do their residency in South Carolina practice in South Carolina. But if you go to medical school in South Carolina and you do your residency in South Carolina, 78% of that group end up practicing in South Carolina. So we've been partnering with the South Carolina Department of Health and Human Services. They're doing tremendous work, and the legislature is doing tremendous work funding them on addressing retention of medical students and residents to ultimately, I mean, if we're pumping out more medical students, pumping out more residents, but not retaining them, we're doing nothing.
Okay.
And so we've got to figure out how to retain them. And HHS is working on, they've just issued a new funding mechanism to try to retain, so we increase the physician supply in South Carolina.
So you mentioned the fact that more slots are open in residency programs now. Is that across most specialties, or is it more primary care, or where do you see the biggest need?
Well, the biggest need is obviously primary care. That's where
family medicine, pediatrics,
OBGYN, those are specialties that every state needs, and South Carolina is no exception.
Okay.
So that's where a lot of the focus is. However, there is not a specialty in South Carolina that doesn't need more physicians.
Okay.
So we can't ignore any specialty. You can have plenty of primary care doctors, but if you don't have the orthopedist that fixed the broken bone that they identified, then you still have a problem.
Sure.
So we're focusing on all physicians, but certainly focusing on primary care primarily.
And that's part of the Health and Human Services Initiative, is enhanced reimbursement for the specialties we need in South Carolina.
Sure. So for the physicians who leave the state, what are their primary reasons for that? Just better opportunities, or what?
Sometimes it is better opportunities. Obviously, it's different for every person.
Okay.
But South Carolina is not known for reimbursing physicians well with some of these programs we're discussing. And that's one of the reasons why we feel like there's some room to grow in those areas. And we are working with the legislature in trying to increase reimbursement so that we can keep physicians in our state.
Okay. I imagine that's both at the state level and, of course, federal, too, depending on the CMS or Centers for Medicare, Medicaid.
Absolutely. And then we also have the cost of education. So many physicians graduate with approximately $250,000 of healthcare debt or debt from education. So one of the focuses we have is potentially helping to get rid of that debt in a manner which, if they practice in South Carolina, especially in certain areas, we're hoping that the state will be able to help those physicians retire some of that debt. We feel like that is an option that could help keep physicians in South Carolina where we need them.
You spoke earlier about trying to attract people into medicine to begin with, into medical school. And what's the enrollment like these days? Because people have lots of options now as far as which healthcare career to focus on. So is enrollment down a little bit from where it was many years ago, or it's still pretty sky high?
No, there's plenty of people that want to be physicians.
Okay.
So the enrollment in the actual classes, they're filled every year.
Okay.
So that's not a problem. There are some issues occasionally in some of the specialties, like we talked about, some of the specialties. For example, primary care. You say you graduate from medical school and you have $250,000 of debt. That can influence what you choose to do because you need to pay off that debt. So we believe that if you can help reduce that debt, then those students that really want to be a primary care doctor in a small rural town in South Carolina, we feel like they'd be more likely to choose that if they didn't have as high of a debt.
Sure. Well, obviously, physician-led healthcare is the gold standard. You argue that really well. To play devil's advocate, there are more than half the states, about 27, I think it is, that enable nurse practitioners, for example, to work independently of physicians. And allegedly, it's going pretty well. Wouldn't that be a good idea here in this state, with having such poor access to care, to expand that? PAs, nurse practitioners, and so forth. What's the argument there?
Nurse practitioners and PAs in South Carolina already have the same scope of practice. They can diagnose, they can treat, they can prescribe. What they have to do is have a collaborative practice agreement or a supervision relationship with the physician. Back in 2018, the mileage restriction was eliminated in South Carolina.
Okay.
So a nurse practitioner or a PA does not have to be within a certain proximity of the physician who is supervising them or who they're collaborating with.
Okay.
So there's nothing now that prohibits nurse practitioners or PAs from moving to rural areas with a supervising or collaborating physician in a more urban area. That is now, telehealth has expanded the capabilities.
Right.
So the physician has to be available to the nurse practitioner and the PA through electronic means if they're not physically present. So we haven't seen, when those mileage restrictions were eliminated in 2018, we haven't seen the rural access issue solved by eliminating that requirement. We believe that healthcare is designed to be a team sport. There are better outcomes, and there's lots of data to support that the best outcomes are when physicians, nurse practitioners, and PAs practice together as a team. A nurse practitioner and a PA is just as valuable to the patient as the physician. But when it's done in a team model, there are better outcomes and lower cost care for patients.
Okay.
So while the reimbursement for the nurse practitioner or the PA may be less upfront, there's lots of data that shows that nurse practitioners and PAs order more tests. They prescribe opioids, they prescribe antibiotics at a higher rate. Those kinds of things that require more tests, more prescribing, ultimately increase the cost of healthcare. So we think it's an all solution, not just increase the physician workforce. Nurse practitioners have increased by 195% in South Carolina over the last decade. What that has created on the back end, though, is that we are facing the 7th largest RN shortage in South Carolina. So we can't just increase nurse practitioners. We can't just increase physicians. We need it across the board. And so we think conversations like severing the team relationship is actually detrimental to the conversation. We should be all at the same table figuring out how do we move forward together to address the needs of patients and not try to break up the team when those are the best outcomes for South Carolina patients.
I know things have changed significantly in my career. When I had black hair, now it's like silver. We have these new professions, the physician's assistants, the nurse practitioners, and others. And interesting phenomena is that many programs these days, nurse practitioners, the nurse anesthetists, physical therapists, pharmacists, they're all PhD level programs now. So these are really doctors coming out, not doctors of medicine, but they do have a PhD. Do you take a position on that with having any of these healthcare providers referring to themselves as doctor versus a medical doctor? Just curious.
It's confusing to the patients to not have a physician most people see that as a doctor in medical school. So if you're in a healthcare situation, it can be confusing. So that's something we think should be clarified in the future. It is confusing for patients. Patients do want to see physicians. They want their healthcare guided by physicians. So we have no problem with people getting their PhDs. We think is wonderful. And we have no problem with getting more nurse practitioners, more PAs, more CRNAs in our state. We need more healthcare providers. Our main problem is that when you try to remove the physician as the director of healthcare, we think that's a detriment to patients.
And Senator Verdon introduced a bill called the Team-Based Healthcare Act this past legislative session, and in it addresses that issue.
Okay.
It allows practitioners other than physicians who have earned a doctorate level degree to call themselves doctor after they've disclosed to the patient what that means.
Okay.
Because it's important as a part of the informed consent process for the patient to understand who they're receiving care from.
Sure.
So before you introduce yourself as doctor, you need to explain to the patient what that means.
Sure. One thing that was interesting to me, I was not aware of, pharmacists obviously are a vital component of the healthcare system. There's legislation now, I guess, I don't know if it's here, but in other areas, to allow them to have prescribing privileges, order labs, and that sort of thing. What's the upside to that maybe, and then what's the downside to that?
Well, pharmacists are pharmacists, and they go to pharmacy school, and they learn a lot about medications. They don't really learn a lot about diagnosing diseases. So we feel like that's firmly in the lane of physicians.
Okay.
And if you've ever been to your pharmacy, which I have lately, they're extraordinarily busy doing their job of dispensing medications and making sure patients understand what their medications do for them and how they interact. Adding on an additional burden of diagnosing diseases, we don't think it's the right setting for that service.
Okay. And there's two initiatives in the legislature that have kind of addressed that. One, if you've been following the PBM conversations in the Senate and the House, what you'll hear pharmacists testify to is pay us for what we're trained to do first. We're not getting paid fairly a prescribing fee. That's what they're trained to do, is to help a patient navigate what drugs they should be on. So their first goal is pay us for what we're trained to do.
Sure.
Secondly, there's a piece of legislation called collaborative practice agreements, and we support that legislation. It's another Senator Verdon bill. It would allow physicians and pharmacists to collaborate on an identified set of patients. So let's say that Dr. Butehorn had a group of patients. He wouldn't because he's an ENT, but let's say he had a group of patients who were diabetics, and he thinks together he and the pharmacist can help manage the diabetes, their levels. Together they could enter a collaborative practice agreement and treat those identified patients together. We think that's again, back to the team-based concept.
Sure.
We think that's a perfectly appropriate way for physicians and pharmacists to collaborate together. So first, pay pharmacists for what they're trained to do. And then two, yes, if there's a way to collaborate with physicians for them to do more, particularly in rural areas, we think it's perfectly appropriate.
So the South Carolina Medical Association has a lot of clout. And if you were to look into the camera now and speak just to one of the legislators, member of the House or member of the Senate, what are some of the one or two top things that you would like them to know or do?
Sure. So I would start by saying thank you to our General Assembly. They have been very supportive of healthcare and increasing access to care in South Carolina. What I would say is to continue, our focus and what we hope your focus will be is continue to support physician-led healthcare in South Carolina. Continue to look for ways to increase the physician workforce. So there's lots of ways to do that. And then also, we need to talk about things like repeal of non-compete agreements. We need to have conversations about increased reimbursement. All of those things are things that are on the agenda. But two top priorities, if I had to identify with them, would be supporting physician-led healthcare and increasing the physician workforce in South Carolina.
Okay. Anything else from your standpoint?
I think Holly's brought up the major issues. I would say simply, I would like our senators and representatives to contact their local physician and talk to them about the healthcare issues that are on the docket every session. Many times, our legislators do not get the opinions of their physicians, and physicians really understand how healthcare is run and how different issues will affect them and their patients. So our primary concern, our primary thing I would say to legislators are call your local physician, talk to them about the issues you're dealing with in Columbia, and we can help you figure out how it will affect your patients, your constituents, and how we can help them continue to have good healthcare in South Carolina.
Okay. Well, you've both got passion for this, obviously. Always curious from a personal standpoint. Holly, for example, how did you get into this line of work with the SCMA or after law school? What was the path there?
Sure. So my first job out of law school was with Nelson Mullins on the healthcare litigation team. And I actually begun by litigating certificate of need cases.
Oh, wow.
So was very well informed during that conversation about how certificate of need is used in the marketplace.
Sure.
And then a lot of my career has focused around healthcare and healthcare policy in South Carolina.
Yeah.
My family has had some major medical issues we've faced. So I hold certain physicians near and dear to my heart.
Wow.
And I see how they benefit South Carolina patients. I see how they can benefit individual patients. And so I care a lot about physicians. I think they do really important work. And I think my background has prepared me to advocate on their behalf.
Well, it's personal, not just professional.
Yes.
But Dr. Butehorn, you're a busy guy. You've got your own practice. Tell us about that. It's one of the longest named specialties, otorhinolaryngology, if I got that right.
Yes,
So tell us about your practice and why you made the move to join the SCMA and then become its leader.
Well, thank you for that question. I've practiced in Spartanburg, South Carolina. We have two offices in Spartanburg and Greer. We're an independent otolaryngology head and neck surgery practice. I've been there for over 20 years now. I have a real passion for taking care of my community. That's what brought me back to South Carolina. I did do my medical school at the Medical University of South Carolina, where I was first a member of the SCMA, and I've been a member ever since then. When I first came back to South Carolina, there was problems with the tort system, and there was big issues with medical malpractice, and it was extremely expensive. So that really got me motivated to start participating with my county medical society. They asked me to be a member of their board, and I slowly learned about the legislative process through that. We got in a bus, literally drove down to Columbia. That's where I first started meeting legislators. And through that process, I learned about how the SCMA is a strong voice down at the State House, and I wanted to become more involved. So eventually I got asked to be the trustee, which is the local representative for the SCMA. And then through that process, my SCMA colleagues have elected me. I think I was the last one standing, but I appreciate their confidence in me, and I can't do it without all the other physicians that have also given their time. This is a volunteer organization, so all of us are very passionate about healthcare, our profession, and primarily making sure that physicians and patients have that relationship they both deserve.
Wow. All right. Well, Holly Pisarik, Dr. Fritz Butehorn, thank you so much for joining us here on the Health Links podcast.
Thank you for having us.
Thank you for watching. For any information regarding our Health Links podcast, the magazine, or anything Health Links related, check us out on the web at healthlinkssc.com.